Hello friends, welcome to Cortex YouTube channel. In the last one of the shots, I have asked you regarding question number 4. That question goes like this. A young female with intentional polypharmacy overdose, her heart rate is 72, which is regular, and BP is around 100 by 62, and GCS is 15. Her ECG is given below. What is the diagnosis they are asked? So, that question's answer is going to be discussed in this video. Please watch it carefully. This is an interesting ECG to interpret. So, as usual, we'll start with rhythm, rate, and axis. Okay, let's calculate the rhythm of this ECG. So, for that, you have to see lead 2. So, look at the lead 2 here. So, there are P waves, QRS, P wave followed by QRS, P wave followed by QRS. So every P wave is followed by QRS. Okay, all the P waves are looking similar. Okay, that means the origin of P waves is one and only one, that is your sinus node in this case. Next, okay, look at the RR interval. Sorry, look at the RR interval. It is regular. So the given ECG is in sinus rhythm. Next, rate they have already given 72 here. Let's calculate nevertheless. So let rate you have to calculate by the calculating the number of big boxes between two RR waves. So okay, it's easy to calculate here. This is one big box, this is 2, 3 and 4. So 1, 2, 3, 4 big boxes means 300 divided by 4 means 72, 75. Okay, it's coming 75 beats per minute. Okay, next axis. So if you calculate the axis here, so for that you have to see the look at the lead 1 and lead AVF. So here lead 1 is predominantly negative, lead AVF is also predominantly negative, so both are going in a negative direction. That means it is extreme axis deviation or it's northwest axis. So it's also suggested or it's also pointed by the dominant R wave in AVR. So AVR dominant R wave again suggests that there is a northwest axis or rightward axis deviation of terminal QRS. So let me write the findings here. So it is a sinus rhythm. I'll write here, next page. Sinus rhythm. Next, rate is around 75 beats per minute. Next, axis is extreme axis deviation or northwest axis. So now if you look at the only abnormality in this is extreme axis deviation. Okay, next you have to look at the waves. Look at the QRS. What happened here? QRS looks broad. So anything more than 110 is millisecond is considered as broad QRS. So obviously here the QRS is broad. Like if you calculate from here to here, 1 2 3 4 5 small boxes means more 200 milliseconds. So here it's almost 200 milliseconds. So it is broad. So it's almost 200. It's less than, actually it's less. If you calculate properly, it comes around 160 milliseconds. So you have to calculate from here 1 2 3 4. So 4 means 4 is 160. Okay, it comes around 160 milliseconds. Let's take it as 160 only. Next, after this we have to see there is predominant R wave in AVR, as I said before, which is abnormal condition. So next, okay, if you see the QT interval, what happened to QT interval here from here to here? So one box, what happened to QT interval here? Okay, the easy way to calculate here is we will calculate from here 1 2 3 and 4. So 1 2 3 boxes are there. 3 boxes. So 3 boxes means it's almost near 600. But if you calculate from here, so it is 600 minus 80, it comes around 510. It's actually, if you calculate it properly, it comes around 460 milliseconds. So absolute QT interval is around 460. So abnormal, I'm writing only abnormal things here. So There is dominant, okay, that is suggested by axis, right, extreme axis deviation. Next, what is there is broad QRS. Broad QRS, that is around 60 milliseconds. Next is QT interval is prolonged, that's around 1460 milliseconds. Next, what is abnormal here you have to notice is, if you see the PR interval, what happened to PR interval here? Look at the PR interval. So sorry, PR interval, this is the starting of the P, this is the end starting of the QRS. So 1 2 3 4 5 6 small boxes. 6 small boxes means 240 milliseconds. The PR interval is around 6 into 40 milliseconds, it's around 240 milliseconds. So which is prolonged. Anything more than 200, PR interval is prolonged. So there is abnormality. What are the abnormal that are there means PR interval is prolonged. That suggests what? AV blockade, and there is prolonged QRS. QRS is prolonged means intraventricular conduction delay is there. So that suggests sodium channel blockade, and QT interval is prolonged means there is potassium channel blockade. So the three important toxicological parameters or findings that are there in this ECG is, I'll write down here once more, that is your prolonged PR interval, that prolonged PR interval suggests AV blockade and atrioventricular blockade, AV nodal blockade. Next, one more finding is broad QRS. Broad QRS suggests what? Intraventricular conduction delay, that suggests sodium channel blockade. Next, prolonged QT interval. That suggests potassium channel blockade. So these are the three important toxicological findings in the given ECG. So if you apply this, and if you dig the history, and if you take the history properly, the patient gave history of consumption of flecainide around 2500 milligrams of flecainide, oral flecainide immediate release formulation is consumed by this patient. So flecainide is nothing but your class 1C antiarrhythmic, which has the property of sodium and potassium channel blockade. So because of this the patient is having this ECG pattern. So sodium channel blockade is also seen in TCA toxicity. So TCA toxicity. So if you will discuss what the ECG patterns in various channel blockades. See, sodium channel, if you block sodium channel block, so what do you get? Sodium channel blockade will cause broad QRS. Where do you see? In carbamazepine, anti-epileptic carbamazepine, and in class 1 anti-arrhythmic drugs. Next, in TCA and in propranolol. Okay. Next, this is about sodium channel blockade. So if potassium efflux is blocked, then what are the features that you get? You get prolonged QT. So what are the drugs? Your antipsychotics like TCAs, and class 1 and class 3 anti-arrhythmic drugs. So if you block calcium channels, what are the findings that you get? So you get bradycardia, that is because of prolonged PR. So what are your drugs? Verapamil and diltiazem, no need to mention. And if you block beta channel, sorry, what is that, beta blockers, if you block beta receptors, again you will get prolonged PR. So your drugs includes your atenolol, metoprolol, propranolol, and sotalol. Okay, so these are the various channel blocker and their ECG features. This is high yielding, and you have to remember there is no other point. Okay, next. So next, if you see, okay, let me throw a few points on flecainide overdose. Flecainide overdose. Flecainide overdose. So flecainide overdose. What is flecainide? Flecainide is nothing but your class 1C antiarrhythmic drug. So it exerts its action through potent blockade of sodium ion. So it blocks sodium ion potassium channels. Okay. Okay. Toxic dose is not well established, but it is seen with ingestion as low as 5 times usual daily dose. So it affects at therapeutic levels are greatest on the His-Purkinje fibers and ventricular myocardium, but with increasing toxicity, with increasing dose, it extends to the AV node and atria and also causes left ventricular dysfunction. So at therapeutic level, it acts on more on His-Purkinje. So action is more. Action on bundle of his and Purkinje fibers. As the dose increases, dose keep on increases, so you get involvement of ventricular myocardium and AV node and your atria and your LV dysfunction. So as the dose increases or as the toxicity increases, you get effects on AV node, atria and left ventricular dysfunction. So so QRS duration is very important in flecainide overdose. So QRS is very important. Duration is very important. So flecainide overdose can present as two different entities, like QRS interval less than 200, QRS more than 200. If it is more than 200, death rate is more. Incidence of death rate is more. And if it is less than 200, death rate is less, and it presents as RBBB pattern, right bundle branch pattern. Here it presents as left bundle branch patterns, and here P waves will be absent, here P waves will be present. So these are the two important differentiating factors when QRS presents as less than 200 and when it is more than 200. So more than 200, QRS more than 200 in flecainide overdose patients, it's very dangerous. So in our patient, QRS was around 160, which is less than 200. So this patient got recovered without any events. Okay. So yeah, this is it. If you like this video, please like, share and subscribe, and comment below your opinions or advice to improve this quality of the videos. Thank you.